So good afternoon, everyone. I'm Wendy Spearman. I'm going to be your moderator for the panel session on management of non-alcoholic fatty liver disease in Africa. And we'd really like to thank our speakers, Jeff, Joel, and Ponciano, for this excellent overview of NAFLD in Africa, really emphasizing the lack of the recognition of this important disease, and then really showing us the importance of diabetes, obesity, and its impact on COVID-19. Also like to welcome to our panel Mark Sondrop, my colleague at the University of Cape Town, the liver unit there, and he's going to join us on the panel. He is well known to many of us and has an interest in viral hepatitis, management of NAFLD, and drug-induced liver injuries. So we really look forward to a very interactive discussions, and I think to kick off the questions whilst we wait for some questions from our participants, probably address this to you, Jeff. What do you think really are the main drivers of non-alcoholic fatty liver disease in this day, and how do we address it? And then importantly, is fibrosis that is associated with Nash and cirrhosis actually reversible? So over to you for the first question, Jeff.
Great, thank you very much, Wendy, and greetings to the other panelists. Thanks for the great presentations. Well, I think you already mentioned, both diabetes and obesity. I mean, in the context of COVID-19 and in the context of NAFLD, I mean, these are the common enemies. So when we talk about how to address NAFLD and Nash in lower resource settings and with many competing priorities, I hope that we can all start to agree that obesity and diabetes are key drivers of really both epidemics, both pandemics. And then linked, to obesity are issues around, general lifestyle issues that require behavior change, more exercise, healthier eating, etc. So big societal issues, but the world is focused right now for a change on, diabetes and obesity, given that they're common COVID-19 causes of mortality. Regarding the reversal of fibrosis, well, in the early stages, if we diagnose early enough in F1 and F2, it can be reversed with the proper lifestyle changes, not in all cases, and some of the clinicians will probably want to comment further on that, but fibrosis is reversible.
Thanks, Red. So, Ponciano, we've heard that, in fact, there are very few guidelines in sub-Saharan Africa that actually specifically address non-alcoholic fatty liver disease. What are we doing at present to actually change the situation? Are there processes in place that we are developing guidelines? Do you know of anything, and how should we approach this? Ponciano.
Thank you very much, Wendy. I think one of the main issues here is the recognition of the condition. I think politicians would like really to know what you are talking about in terms of how much you have, what is this thing called fatty liver, and how much is it, and the impact after some time. And so I think one of the issues that now we need to take on really is the issue of getting data that we can use to convince, and actually to tell and convince the politicians and policymakers about what we have, and then this will culminate into the development of these guidelines. In most cases, this hasn't been really tackled very well, and because NAFLD will, cause its impact after quite a bit of time. It's not like immediate in a person. The recognition is not as well. So we need to work very hard to try to achieve this. And I think I love what Jeff and the colleagues are now doing. And I think we really need to work together and involve Sub-Saharan Africa in some of the happenings, in some of the things we are doing, so that we can identify this menace which we are going to face, and it's going to lead to a loss of lives and also and money actually in the population. Thank you.
Thanks, Ponciano. So just moving on to, before we open it up to some more general discussion, Joel, I mean, you've realized when we were looking at our guidelines for hypertension, diabetes, obesity. In fact, the mention of NAFLD is almost hardly there. So what do you think we should be doing, particularly in light of the fact that you've shown us that diabetes, obesity has a major impact on COVID-19 outcomes, and COVID's going to be around for some time? How should we be addressing these changes in actually bringing to the fore the importance of these cofactors and the development of NAFLD?
Thank you very much, Wendy. So obviously for a long time, the world has been focused on communicable diseases. And clearly now in this era of COVID-19, the world again is focused on COVID-19. And you know, with resource allocation, it's often a problem in all parts of the world. So there's no doubt that there are multiple diseases that deserve a lot of attention and resources. But if we focus, I think, just on the non-communicable diseases, then really intensively tackling something just like obesity is likely to make a huge impact on the prevalence and progression of many of the other diseases, such as NAFLD, type 2 diabetes, the metabolic syndrome, and insulin resistance, dyslipidemia, and hypertension. And the problem is that if you ever look at people with just one NCD, it's massive numbers, making the tackling of NCDs complex. So I think it's very important to, in all guidelines, mention the strong association between everything that's been mentioned, the metabolic syndrome, NAFLD, type 2 diabetes, and obesity. And I think from now on, instead of having diabetes educators and specific educators on specific things, there should be well-trained NCD nurses, advocates, counselors. And I think that really makes it realistic, as one is likely to make a great impact on many disease processes via intensive education and behavior modification with respect to essentially lifestyle measures such as diet and exercise. So I think NAFLD hasn't gained prominence in many of the guidelines. I think it's by time that we do it. And I think because of the strong association of all those factors that make up the metabolic syndrome, I think they should all be connected together so that they tackled together under the whole NCD banner.
Thanks, Joel. So Mark, I mean, as you know, we deal with a lot of non-alcoholic fatty liver disease in our clinics, and they range really from steatosis to Nash to cirrhosis. But if we're going to really address the significant burden, there's really no way that hepatologists, gastroenterologists can be responsible for the management alone. How do you think we should go about actually addressing this in terms of the NAFLD side of it and the liver side of it? Who do you think we should down refer? How do we actually educate people in terms of management of NAFLD?
Yeah, good afternoon, Wendy. Thank you for the question, and to my colleagues on the panel and those joining COLDA, good afternoon as well. I mean, I think we need to wind the clock back and ask ourselves, you know, what is the base reasons that have been elucidated by Ponciano and Joel to an extent for the risk factors for developing NAFLD. And I think just like we talk about viral hepatitis and other preventable interventions for infections and other conditions, we need to look at prevention here rather than actually try to start solving the problem when it's already emerged. So we know that type 2 diabetes, metabolic syndrome, et cetera, are the base factors in all of this. And of course, we need to have a discussion around Africans and perhaps their lower propensity to progression to Nash. That's a different discussion. But ultimately, fatty liver disease is clearly on the rise within the African context. And it's on the rise given the reasons Joel just elucidated on earlier. And that's the rise, for example, in type 2 diabetes we're seeing and other NCDs that contribute to the metabolic syndrome. So I think it's a complex question as to exactly who must take care of it. But I would premise my answer by saying, can we please deal with prevention? And therefore it becomes primary care focus on prevention, management, tight regulation of actual diabetes, glycemic control, hypertension management, dealing with obesity, overweight, and other metabolic factors. And then ultimately, when we get into the point of target organ or end organ involvement, we should then obviously that should be within the domain of the specialists managing liver disease. But we want to prevent that because we don't have the capacity to deal with the numbers that are potentially coming down the pipeline.
Thanks, Mark. So, I mean, I think what Joel showed us that obesity, poorly controlled diabetes, hypertension has quite a significant impact on progression to severe COVID-19 and mortality. And maybe that is where we should try and actually drive home the need for lifestyle changes. Coming through this pandemic, it's potentially an opportunity to utilize this to actually improve education. So maybe I can open that up to the panel. Does anybody want to take that up in terms of how we could actually utilize this knowledge that we've actually gained, and in fact the public has probably gained? Maybe Joel.
I think Wendy, I hope our policymakers and our politicians have sat back and noticed what has happened, because especially here in South Africa, obviously for many years communicable diseases have gained prominence and have got a lot of the resources, to the point where we have multiple clinics for HIV and multiple clinics for TB, yet the rest of non-communicable diseases sort of share the rest. So I hope they've seen that there's a strong intersection between non-communicable diseases and communicable diseases, and that the NCDs can place a great burden on the healthcare system in times like a pandemic if they're not controlled. I then also hope the public have noticed, because it's been quite prominent in the press, how being overweight and having diabetes does confer a negative path once diagnosed with COVID-19. So one hopes that people will change their ways in the future and improve, and all of us improve our lifestyle measures to promote weight loss and a BMI that's close to where we should be.
Absolutely. Pansiona, I mean, what do you think about sort of combining the approach to diabetes, hypertension, obesity within our TB, HIV, and viral hepatitis clinics? Because, I mean, the reality is that we have limited resources, so we need to use what we have, what is well established on the ground. And we've seen with COVID-19 the important role of community health workers, how they've been used to actually sort of drive actually screening patients, contacting them, being very important. And what is your feeling about using the community healthcare workers in a greater, to a greater extent to actually address these very important basic problems that we're all facing?
I think it is becoming more and more important to really have everybody involved in whatever we are doing, especially in Sub-Saharan Africa, where we have got a limited number of healthcare workers. And like Jeff said earlier, if we are going to leave the care and treatment of NAFLD, for example, into the hands of the gastroenterologists, hepatologists, and there are very few in Uganda here. We are not more than 5 for a population of 41 million. Certainly we cannot do this. I mean, especially when we look at the trajectory that we talked about earlier on. I think there should be quite a bit of education of the other healthcare workers and involvement of the community healthcare workers. And that, of course, will go along with the training and getting the correct information right out there in a very simple term that a community healthcare worker can actually bring out to the population to see how, especially about the prevention methods and mechanisms that need to be put in place. Certainly, I know that in Africa, it is going to be a big challenge if this epidemic really gets here. It is already there, but I think it can only get worse. And so a lot of education is required, and the community healthcare workers are very pertinent in handling some of these sections. And so really we need to work together, as well as task shifting to the other healthcare workers as well to handle some of these conditions.
Thanks, Ponsia. We've got a question from Alexander Stockdale, really wanting to know which public health measures do you think will be most effective for policymakers in sub-Saharan Africa in context to prevent obesity, diabetes, metabolic syndrome? Maybe I can address that to you, Jeff, and then open it up to the panel.
Yeah, well, I mean, which public health policies? I mean, it's about understanding what's in the food we eat and controlling to the extent we can, what goes into into that food and how healthy it is, and explaining that to the public. And it's about facilitating the ability to exercise. Most of our cities and urban areas really aren't fit for purpose. I realize I'm now referring to an entire continent, and some places will be easier than others, but it's not always easy to walk or bike or really exercise in many of the urban environments. So I think the public health measures can be quite simple about increasing the number of green spaces and doing what we can to improve the food supply. It was interesting to see the example from Oaxaca, Mexico, where they were banning sales of fizzy drinks at a time when Coca-Cola was also making it cheaper to buy fizzy drinks. And I mean, there are things the authorities can do. It's a stepwise process.
Yeah, I mean, I think Ponciano showed in his slides the difference between the rural and the urban areas. And we know that many countries are still in a sort of transition phase in terms of nutrition. And maybe that's something that we should be addressing more actively, more publicly, with a lot of education. Joel, maybe you want to comment on that. How could we, in terms of address this transition in nutrition from rural to urban?
Thanks, Wendy. Just to add to what Jeff was saying, and the policies that I think could be put in place. Recently South Africa instituted a sugar tax. Now there's been a wide debate as to whether a sugar tax actually works. I think if it works, that's great. But if it doesn't, I think it is a way of generating a huge amount of money that, if directed into the right direction, of exactly what Ponciano was saying, that we need more healthcare workers, we need more education programs, then I think something like a sugar tax is worth it. I think policies on labeling of foods is very important to ensure that people actually know what they're taking in. And then I think also I'm a firm supporter of some type of regulation of the foods that are allowed to be sold at school tuck shops, and especially in government schools. There is some regulation in other countries, because I think it happens from a very early age where we develop our good and our bad habits. So I think we should drive that good habits are formed at a very young age. It's difficult to know what to do about the rural to urban spread. Clearly, these very poor socioeconomic times are driving people out of the rural areas and into urban areas in search of work. Once they're in the urban areas, they're flooded with a bunch of access to bad types of food. And unfortunately, the bad types of food are generally the cheapest and the ones that the majority can afford, and usually high carbohydrate based. So I don't know, perhaps some type of government subsidies for fruit and vegetables, because because those are actually quite expensive, and the high carbohydrate rich foods are generally the cheapest and fill one more. So I think a lot of work and multidisciplinary work is needed, but I think if people, there's, I think, enough creative people out there to create better plans than are available at the moment.
Yeah, so maybe rather than just having a sort of punitive sugar tax, have a positive tax in that the healthy foods are cheaper and more accessible. And also looking at potentially fruit and vegetable gardens that can be increasingly used in communities.
100%. And also one thing I was going to add is like reduced VAT on like healthy foods, perhaps, is one way. So that would lower prices of those types of foods.
We've got a few questions from our attendees. The next one comes from Hallie Michael Desselin. How about slim NASH? Do you think it might also be an issue here in the case, as is in the case of India? Maybe I can address that to you, Mark, the problem with slim NASH, and do we actually see it here in Africa?
Yeah, I mean, it's a great question from Hallie Michael. Yeah, I mean, I think I'm not going to spend time on the phenotype of what's called lean NASH, which I think is very much an Asian type phenotype that has been described and is well seen clinically. As to whether it occurs in Africa, I think to answer the question, we need to start off from the position that Ponsiamo alluded to. I mean, we have an absolute dearth of data from Africa with respect to NAFLD and NASH, and to members attending COLDA, you know, it's an area of research waiting to explode, because we are now clearly more aware of a number of clear issues that have emerged over the last 15, 20 years. If we sort of wind the clock back at the start of, let's call it the NAFLD knowledge era, then it's always been apparent that early on the potential risk or rates of actual NASH in Africans, and most of the data was really from the US, it was African Americans, was always consistently much lower than those of their Hispanic or Caucasian counterparts. And initially there was some suggestion that maybe it's also about access and disparities and access to care, and the fact that African Americans weren't necessarily represented in trials and studies. That's perhaps over time fallen away, because I think we've now clearly have evidence emerging that due to a host of factors, the risk of progression to actual NASH from simple fatty liver in Africans seems to be consistently lower than that of their other ethnic counterparts. Got some recent, I mean, very early on, it was always suggested that there clearly is a genetic predisposition, and PNPLA3 was always put forward as the potential gene. There's a very nice GWAS data out very recently looking at multi-ethnic groups within the USA. And interestingly, in the GWAS study of really many thousands of people with NAFLD, it showed consistently that African Americans had the lowest prevalence of the PNPLA polymorphism associated with fat content in the liver, for example. And also it correlated very well with the HOMA-IR and risk of insulin resistance. So I think clearly there's a genetic predisposition. And with respect to the microbiome, I'm not an expert, but it probably is another factor. Now, I think to answer Hallie Michael's question in a very circuitous way, does lean NASH exist in Africa? It probably does. But I think if we look at NAFLD and NASH within Africa, it's probably the more typical phenotype that tends to dominate. I think the really interesting thing is, why do we have these consistent lower rates reported of NASH to date? Are we at the beginning of the sort of at the rise of what we're seeing? Are we still going to see it emerge? Are we behind the curve, so to speak? I think it's difficult to say, but I think there's a lot of unanswered questions and potentially answers waiting to be determined within the African context in this particular arena that may actually answer many questions around the progression of NAFLD.
Thanks, Mark. There's another question from one of our attendees, and I'll address this to Ponsiano. Very similar in terms of what is the predominant area of fat distribution in Africans of NAFLD? Is the fat carried around the hips, or is it truncal? And this also relates back to potentially slim NASH. So Ponsiano, in terms of distribution of the fat, mainly truncal or around the hips, and does this make a difference?
I think the waist circumference has been shown to really consistently, be associated with this NAFLD, and so I think really doesn't matter. So what we see is many people that come to the clinic who are obese. You certainly, if you do the scan, you're going to see that they will always report there's some fat in the liver or something. But like Mark said, it is not necessarily NASH. but you see a number of them. Sometimes when people walk in the clinic, and they come in with their ultrasound reports, or you send them and you do scans, you almost tell that this one, we are going to get some kind of fatty liver being shown on the ultrasound scan. And so yes, the waist circumference is important, but even general obesity generally, it's related to the same.
Thanks very much. So we're coming towards the end of our session, and maybe the last question for Jeff. So we've heard that we need education, we need to change things at community levels, school levels, government levels, Department of Health levels. So ultimately we need data, and we've heard that in fact there's really little data from sub-Saharan Africa. How do we improve registries? How do we set about starting registries in individual countries? I think that's very important, because of knowledge, that's how you can influence policy. Otherwise we have really no ammunition. So maybe
if you're talking about starting NAFLD registries, it's going to be quite challenging, and I think the colleagues on the panel could address that. I'm all for more research, more registries, but I mean, I really think that we know, and we've discussed on the panel, and in the presentations, the main drivers of NAFLD. And I think we need to really start, as Mark said, and Joel, focusing on the prevention where we can, stepwise, and hitting it as many ways as we can. In some settings, it will be what can be sold in schools, and other it will be a sugar tax. Somewhere else, it will be more parks in an urban setting. And then I think it'll probably be more at the clinic level that we start to, some of the hepatologists start to have that ability to, to make small registries, collaborate with other clinics, and build up that way. I don't think in the current situation, and with all of the competing priorities, having a massive registry from the get-go is going to be of major importance. But I'm all for it if someone wants to do it. But I think there's so much we need to be doing in advance of that.
So I think maybe things we could start off. I mean, most of our countries have policies, guidelines on how to manage obesity, hypercholesterolemia, hypertension. And maybe just start highlighting NAFLD, how you actually address it, how you diagnose it, how you manage it. That might be a start.
I'd absolutely say that's a great place to start. I mean, we carried out a European review, and when you looked at guidelines on obesity, guidelines on diabetes, CBD guidelines, NAFLD was almost never mentioned, and liver disease was rarely mentioned. So I think we need to go to our colleagues' guidelines and start working that way to get NAFLD more addressed, and then start highlighting it as an issue. We need allies, and I think we have them now, unfortunately, due to the COVID-19 pandemic. So I think obesity and diabetes is now a common enemy, not just for the NAFLD world, but for in so many other issues.
I think that brings the end of the session. So thanks, Jeff, Joel, Ponciano, and Mark for an excellent discussion. Thanks for our participants for joining us and for their questions.